Our last and next and final speaker today is Dr. Creshelle Nash. Dr. Nash is the Medical Director for Health Equity and Public Programs at Arkansas Blue Cross and Blue Shield. Dr. Nash provides leadership for developing, implementing, and evaluating health equity initiatives to help create a more inclusive and non-discriminatory healthcare system throughout Arkansas. A significant part of this work is her leadership role in the Vaccinate the Natural State initiative. Under the leadership of Curtis Barnett, President and CEO of Arkansas Blue Cross and Blue Shield, the company chose to lead the Vaccinate the State campaign, a combined effort from a diverse set of organizations to work to increase the adoption of COVID-19 vaccines across Arkansas, working across business-to-business environments and hyper-local community engagement. Dr. Nash, in her own voice, expresses that she is passionate about addressing health disparities in Arkansas's most vulnerable communities and taking action. Dr. Nash?
Thank you. Thank you. First, let me begin by saying thank you for allowing me to be here to be a part of this important discussion. The previous panelists have been absolutely amazing, and I just want to thank Stacy for sharing that important history. And what I hope that you will see as I talk about my perspective, it will really very quickly illustrate the themes that I hope I can bring home in a timely manner as we wrap up this webinar. So very quickly, I'm going to give you a quick Arkansas context and talk about some of the pandemic activities that will really lead us, that form the background of the lessons learned, and ultimately, as everyone on the call is interested in, implications for health equity. I would like to echo with my previous speakers that while COVID has been a crisis, it has also been an opportunity for us, and people of color are resilient. The mere fact of me being here with you today is evidence of that. And the implications for addressing health equity is really forming the basis of my discussion today. So when I talk about Arkansas in general, I just want to give you just a quick little bit of context. In 2020, United Health Foundation ranked us as 47th out of 50 in overall health outcomes. And we've made some progress, as others have talked about on the phone, in terms of access to health care through our Medicaid expansion in the state of Arkansas. But when we look within the state of Arkansas, our data really does show persistent racial and ethnic health disparities in premature deaths overall and chronic disease and morbidity and mortality. And as we've talked about here, it's a complex interaction of not only history, but social, environmental, socioeconomic, and healthcare system factors. Prior to COVID, Arkansas Blue Cross Blue Shield was already working on how we, as a health plan, address social determinants of health. And some of those ways we were doing that is having a model of community-based case management, meaning that nurses were living and working in communities and engaging boots on the ground with members. We've incorporated social workers in our medical management teams, and we are incorporating using social determinants of health measures into population health stratification. The final thing I'll mention in the pandemic, pre-pandemic and post, is the Blue and You Foundation, where we are trying to address those social determinants of health like food insecurity, like physical activity and youth programs across the state of Arkansas. So as the rest of the nation, and as the previous discussions that my colleagues have had, the pandemic has shown us real-time, really, illuminated specific examples of how COVID-19 has impacted disproportionately communities of color. We've already talked about this, so I won't belabor this, but increased exposure, essential workers, increased prevalence of chronic disease, lack of access to resources, particularly including technology resources. And I'll just give you one example. When we started with the vaccine, you had to go online to make an appointment to get the vaccine. Well, what if you don't have internet access? What if you don't have broadband? What if you don't know how to use the technology? And even access to personal protective equipment. And the final comment I'll make is this is also in the context of job loss, homelessness or near homelessness, as Mr. Watts was making reference to, and evictions. So we really, in spite of the CDC's moratorium, we still had people being evicted from home, and of course, the population that is incarcerated. So this is an example of illustrating the complexity of the factors that we are facing. Just a moment about the current vaccine administration. Although we are making headway nationally, here in the state of Arkansas, 36% of our population, 16 and up, is fully vaccinated, and that varies greatly by geography and by race. I just took a snapshot from this week to show you it varies by county from a low of 19% up to 37%. But if you look on the right, you can see that for each subgroup of color, that the vaccination administration is less than their percentage in the population, and this is the increased risk population as we have defined in previous discussions, with the exception of the Asian population in the state of Arkansas. So you've heard a little bit about Vaccinate the Natural State. So what I want to do is focus in on the community engagement component, which is the part where we are engaging with community-based organizations and trusted partners in working with communities. And what gives me such great excitement about this is because there's an explicit focus on reaching rural, underserved communities and communities that experience these long-term racial and ethnic health disparities that are deep-seated that we've already made reference to. So we have many activities, really, in Vaccinate the Natural State, but I want to go down to responding to local community needs. We are increasing vaccine awareness by messaging and making sure that we have culturally appropriate language and media outreach. We are coordinating with community-based organizations, with government, CBOs, funding mobile units, and really also giving a data support. So really, one of the themes of Vaccinate the Natural State is working side by side with trusted partners who have already been doing this work around health equity in the state and augmenting those relationships. And one of those specific relationships is with the Arkansas Faith Network. And I want to focus in on some key issues around the Delta, which has unique challenges and persistent challenges with a very long history also. But since 2016, my colleagues have been working specifically with the faith-based community that has historically played an important part in not only spiritual health, but physical health in the communities. And this is the same in COVID-19. At this month, or in March actually, they completed a survey with these faith-based leaders to define the barriers that we are seeing that are specific to, we think, minority and rural communities. And some of those barriers you see here: a lack of transportation, lack of technology, capacity to use that technology, a history, again, history is important, a history of mistreatment of African Americans in government funding research, but not just past, in the current healthcare system. We also have to deal with, and we heard about the myths, the concerns about the vaccines that include too quick, short and long-term complications, uncertainty, and the role of systemic racism. The other thing that came out of this work also was that we found that congregations or faith leaders were leaning on the experience of their members in the medical field. So from all of this work, we developed a Delta initiative, and it's a partnership, again, the theme of fostering partnerships across organization partnership between the Arkansas Faith Network, the Arkansas Department of Health, and the Arkansas Medical, Dental, and Pharmaceutical Association, which is an interprofessional group of African American providers, dentists, pharmacists, doctors, PAs, physical therapists, and students. So in this partnership, the activities are really reaching faith-based leaders in rural and communities of color. They're calling it a concierge service. It is outreach, it is information, it is education, but it is about access to resources, including the vaccine in local communities, utilizing health educators and community health workers, but also supported by the expertise of minority healthcare providers, which are a trusted resource in their communities. So when I think about how all of these activities are leading to or telling us what to do in the future, I think about a couple of high-level things. And you've heard this in the other presentations. Data and data analysis is very important to identify health inequities by all of these different factors, but I would also add by social determinants of health. You've heard that from Mr. Watts also. And in the healthcare space, we are starting to be able to do that with Z codes at the individual level, but also at the population level by using the CDC's Social Vulnerability Index. As a healthcare provider, I would also add that the healthcare system needs to address health equity as a component of quality. I believe Mr. Watts made reference to that also. How can you say you have a quality healthcare system if your quality varies by personal characteristics, such as gender, ethnicity, race, geographic location? So what is the future of health equity? I think it's about partnerships. As you've heard, public-private partnerships. We are also engaging the business community, but it's also about cross-sector partnerships to address social determinants of health, whether you're talking about housing, whether you're talking about transportation, technology, environmental issues. We have to link to community social services and resources in the transformation of the healthcare system. We've heard about community health workers. NIHCM has done an excellent webinar in the recent past about community health workers who are expert in their local communities and trusted members. I think the last point here about hesitancy and mistrust must be addressed. I think hesitancy really is too passive a word. It's stronger than that. It's mistrust and community concerns about systemic and structural racism. We've talked about that a little bit here, but I want to make a distinct point here. This is different from interpersonal racism that we have all seen firsthand with cell phones at this point, right? But this is about the systems of discrimination in policies and practices across sectors, whether you're talking about housing, education, employment, criminal justice, environmental policies, or healthcare. And the key point here is that this can happen with or without intention, personal intention, that is. So we need collective action to improve health opportunities in communities of color. So history does matter. There is a history of all people of color in this country that we have to have discussions about in local communities. So as I conclude, I think I want to say that Arkansas, specifically, with all of its challenges that's been highlighted by COVID, is also an opportunity. It has been an opportunity to increase awareness and knowledge about health equity, what it means, what structural racism means, and point to the future and what we need to do about systematic change. And I hope that the themes you have heard are data-driven, evidence-based approaches, public-private partnerships and engaging communities, addressing social determinants of health and the historical systems of disadvantage, but also, more importantly, building community and organizational capacity for future public health or population health improvement. So I hope that I was able to bring it all home to you and take away some key lessons. So I will stop there and say thank you.
Dr. Nash, thank you so much for packing such a powerful and insightful presentation into just a few moments. And